And this morning, it gives me great pleasure to introduce our speaker, Ola Tenkate. He is a professor of medical education at the University Medical Center in Utrecht, the Netherlands, and an adjunct professor at the University of California, San Francisco. After medical school and a PhD in social sciences, he served 4 decades at the universities of Amsterdam and Utrecht, contributing to the curriculum innovation, educational research, and faculty development in health professions education. He is locally, nationally, and internationally known as an expert in medical education, having founded the Center for Research and Development of Education at UMC Utrecht, and was president of the Netherlands Association for Medical Education from 2006 to 2012. He has published and presented extensively with more than 450 manuscripts to his name, and has mentored up to 25 PhD students now. He received the J.P. Hubbard Award of the US MBA, the Ian R. Hart Award, and the NVMO Han Mol Medal, and a Dutch Royal Distinction, and is a fellow of the American Educational Research Association. His interests include, among others, competency-based medical education, entrustable professional activities, and entrustment decision-making in health professions education, which is what he is going to discuss with us today. And if you've ever heard the term entrustable professional activities, you have Dr. Tenkate to thank for that, because it was his work that brought this all to our attention. And with that, welcome, Dr. Tenkate.
Thank you. Thank you very much. And let me just immediately share my screen. Here we go. And thank you for the honorable invitation to talk to you. And I will be talking about, and I didn't even put entrustable professional activities in my title of the talk, but medical competence is a multi-layered construct. And I'm not going to say that I won't say anything about EPAs, but it is actually embedded in I would say, a somewhat larger, broader topic. So let me start by saying that I have no conflict of interest to disclose, and start a little bit about, if we talk about competence, let's talk about the birth of specifically postgraduate training. In the 19th century, licensed physicians in Europe for about after 6 or 7 years, in North America after 4 years after a bachelor diploma, they were all considered to be competent and ready for practice, and you would now call that general practice. Around 1920, specifically at Johns Hopkins University, postgraduate training was actually started to be structured, you could say, combining both like a mandatory intern year for all physicians, but also a multi-year hospital employment as a resident or house officer under guidance for a small number of people, actually, from a small number of graduates. And resident, of course, as you understand, is just really means living in the hospital, doing clinical and administrative work. And this general experience for a preset number of years was roughly deemed enough to qualify as a specialist. Now, around the turn of this millennium is actually where you could see that competency-based education really has drawn a huge attention. As some people would say, the next advance of graduate medical education, or shifting paradigms. And what is the big shift? Actually, the idea of the big shift is really that fixed period of time was not deemed enough to make sure that everybody meets those expectations. Whereas you would say after a fixed number of fixed number of years, fixed number of procedures, maybe even, that would probably not guarantee that every individual trainee would meet the same expectations. So the idea is actually of that shifting paradigms, from shifting from a fixed period of training time to a fixed outcome paradigm with, if needed, variable time in training. So competency-based medical education then says that the question is when is a doctor competent enough to work without supervision? That is, to deserve a license to practice. Is that the same time for all trainees? the same time for all professional activities that people do. Let's give one example. Here's an example from gastroenterology, where for the activity of performing a colonoscopy, you could see that among 35 residents who were subjected in this study, about a number were ready after like 100 colonoscopies under supervision. Others would need 200, and still others would need 300. So basically, the idea is that would be different. Now, I have a question for you. If you think of individual trainees that you have supervised, if you have been a program director or a clerkship director, can you remember that you have ever signed off for completion of a program of rotation after that fixed period of time, while you were not fully confident that the learner had met critical objectives? So if you have a smartphone, you can take that QR code and see what your answers would be. And meanwhile, I will tell you that we did that in an interview study among anesthesia program directors, anesthesiology program directors in Europe, and actually found that quite a number actually couldn't remember cases that they would actually have personally signed off for completion of training in anesthesiology, while they were not really confident. And it was a minority of graduate, of course, but they can remember those cases. And I have asked this question several times, and this is the typical answer that I have found. And if we can, in a minute, we'll see what your answers are. But basically, this is what we usually find, is that like 60% of people would recognize that they would remember that they would have actually done that. And if we go back to this slide and see if I'll probably have to share another screen. I don't think you can see this. So I'll stop sharing my screen and share the other screen so that you can see what your own answers are here. So there's only 3 people who actually answered this. So this is probably not very representative of your group. Anyway, so I'll go back to my original presentation and show you that this is what we usually find. And if there's more answers coming up during this talk, we might go back to see what your answers are. But this is across over 200 people in audiences that we asked that question. And actually, it's not only even medicine. I was in a conference just a few days ago in Aberdeen, Scotland, where we did that too, and it was typically this type of distribution. So what it actually comes back to, the idea is, if we have, if we do that, you could call those decisions where you are uncomfortable with graduates, you're personally signing off that as like a false positive decision. And we could say that after 20 years of thinking about competency-based education, one of the key authors of that first paper that I showed you, Carol Correccio, is still actually calling for the idea of dismantling fixed time variable outcome education, which is the idea of ready or not, here they come, saying we have to dismantle that, and that's way overdue now. If we do that, actually, if we think of competency-based education, we really want to make competence much more important than the period of time in training, then enhanced requirements for assessment are important. So we have to think of, what are we testing? What are the standards for competence? And we need those standards as a benchmark for teaching and assessment, but are the standards still the same 20 years ago, now, or 20 years from now? Are the standards the same in Utrecht, Sao Paulo, or Cape Town? Or must all hepatobiliary surgeons operate identically? Is there any difference thinkable? how should we determine when professionals are competent? And more generally, are those people who pass their exams, and are those also the same people who we would say we would trust them to and allow them to practice? This brings us actually to a distinction in actually our vision on assessment, and the distinction between retrospective and prospective perspectives of that is the traditional educational perspective on assessment, and that's also for grade school, secondary school, and other all sorts of types of much of tertiary education too, is the question: does a student show the mastery of the content taught in the courses and rotations? If they pass their exams, why not say they're ready for completion of training? On the other hand, in healthcare, in health professions, the more important question is probably, is the student ready to assume the expected future responsibilities? And that may not be exactly the same question. Just going back to the question that I said in the beginning, everybody who passed their exams, are you all confident that they're actually meeting critical objectives for the practice of medicine? And then you come to the word competent here, and we'll go more deeply into what competence actually is. But if you look at the dictionary, competent has two connotations. One is actually the educational one, the ability to do something, and one is a more legal one that says a competent person or a competent body is actually has the authority to judge and to decide. When we look back in history of linguistic history, this is a very old dictionary that I happen to own in my own bookshelf, and so it is called the Pons Asinorum, or the Aid for Dummies, as the Latin says. But here you see the word competence that has both the idea of ability and legal right, which actually is that idea of both something prospective and retrospective. So that's good to keep in mind if we talk about competence. So it's not only that we say, well, the person has the ability, but we really grant them the authority to do things in practice. So if we think of competency-based education, we usually think of those frameworks that have been created, the ACDME framework, or the Canadian framework called CanMed's framework. And they have been embraced in many countries, including in my own country, in the Netherlands, but also in many other countries in the world. At the same time, if you look at the literature, there's quite some criticism on those standards of competencies. People would say competencies are sometimes, some authors would say they are reductionist. They don't really describe what it is to be a physician. Or they would say, well, competence is okay, but it's also context dependent, and that's not really captured in those frameworks very well. Or they would say professional identity formation is important. How does that fit in those competency frameworks? And well, increasingly we think about diversity and individuality among our healthcare workforce. Those ideas of differences or individual differences and diversity is not really served by standards. And then people would say standards lead also sometimes to misused metrics and dysfunctional ranking of individuals. Can we do a better job? So we recently published a paper that actually conceptualized medical competence as a multi-layered construct. And I want to, when presenting this, I want to thank all my co-authors on this paper, also some other people who read along with manuscript of the paper, like Stephen Billett from Australia, Avis Dapramian, and somebody called Anastasia Kulisheva for one of the key elements of that paper. Now, if we think of a multi-layered construct, you could say there is something that you could call canonical competence. That is competence that is independent of context, that everybody should know, and that, like, all physicians should know, or specialists in their domain should know. That's not really dependent on any context where that is applied. So around that, you could say there is contextual competence. That's the ability to apply that canonical knowledge and skills and adapt to any contextual condition or diversity in context, in multiple contexts probably. So that is the competence to do that in a context. And the third layer, and I'll go more deeply into all those layers, but you could call a personalized competence, which is the individuality, or sometimes called the art of patient care. So again, canonical competence would be things like Gray's Anatomy or Harrison's Principle of Internal Medicine, or and then the contextual competence would be knowing the local protocols, knowing how to deal with patients that come into your office, or working with a team that is locally represented in your context. And then personalized competence actually is acknowledging that people are different, professionals are different, and not everybody has to be exactly identical. There is differences that can be valued too. And that makes actually part of patient care, the professional practice, also individualized. So if we think of competence development in 3 layers, like in different phases of development, from a preclinical phase, a clinical phase, postgraduate phase, and after graduate certification, you could see that in this model, we propose that it is hierarchical. So if you don't have canonical knowledge and skills, you cannot apply that in a context. So there is some sequence, but it's not completely sequential. There is, in every phase of development and sustained development until, I would say, retirement from practice, there could be attention to all 3 layers of that competence. So let's start with layer 1. So layer 1 is then called the canonical knowledge and skills, and it's derived from the Greek canon, or the general Catholic law and rule and principle, Bible books, or the established body of work, more or less undisputed. And canonical knowledge would be what everybody should know. Canonical competence in medicine should be kind of the undisputed facts that we know, and that have been sufficiently evidence-based that we think there's no sense in actually to dispute that. And standards should then be hold across contexts and schools. That is, you could apply those standards on a national level, maybe sometimes even international level. A mechanism should be in place, however, for regular updates of that canon. So there should be corrections, should be additions, there should be evolving priorities. But at some point, actually at any point in time, it should be theoretically possible to describe that canon. And the assessment of learners should, and I think can be, reliable and valid if we apply the right procedures to that. Then contextual competence, the second layer, is how residents develop performance in new settings. And this is from a study that was done and actually showing that how residents actually responded. You asked them, how do you work here? And the residents would, this is a typical quote from that qualitative study, residents would say there is a continuous moving between using knowledge and skills, a foundation, but also recognizing where and when contextual difference require new learning and adaptations. So the contextual competence is the ability to apply that canonical knowledge and skill in a clinical context, in effect, in different contexts and varying contexts. So rules and habits and procedures and team members and local protocols should be, and if you work here, you move to a different hospital, you'll have to adapt to that new context. And that requires competence to do that. And layer 2, standards of competence cannot be absolute. They must also be locally interpreted and comply with local conditions. So the assessment should regard and then the readiness to entrust with the healthcare tasks. So whereas the canonical knowledge could be something that is context independent, you could say, well, you can take a test. It could be a written test or a standardized test that is independent of a context. But in a context is where the moment comes, you say, oh, you're now ready, and you can start actually practicing with patients in healthcare. So that means here's where entrustment comes central to the concept. And it should be in teaching, foster progressive autonomy in healthcare practice. If you have in a developmental trajectory, over time, you should get more autonomy in the practice of healthcare. And if you look at what entrust means, the word entrust is to assign the responsibility for something valued, a person or an organization, to put one's trust in a person or organization with regard to a particular task or responsibility. That's derived from the Oxford English Dictionary. And I always like that historical picture that you can see now, where you can see that in the Greek mythology, the Apollo, the god of Apollo, here in this picture is entrusting his son Asclepius with centaur Chiron to be educated in the art of medicine, actually. So here you could see that this is an entrustment decision, that you even would put your own family member in the hands of somebody to be educated, and in this case, to grow into the symbol of medicine, Asclepius. So layer 2, again, contextual competence, is proposing central concepts of entrustable professional activities and entrustment decision-making. And again, you're probably familiar with this definition, but I'll just reiterate it. An entrustable professional activity is a unit of professional practice. You can think of it as a task or responsibility that can be fully entrusted to a trainee once he or she has demonstrated the necessary competence to execute that activity unsupervised. And the purpose is to operationalize competency-based medical education through a stepwise and safe engagement of trainees in clinical practice with progressive autonomy. And if you operationally define the word competent, then in this sense, it is when a professional activity is mastered at a threshold level that would allow us to trust the learner to act unsupervised. And if you think of that, it's a stage in a developmental continuum. And if that continuum looks like this, and you would apply developmental steps here, from novice to advanced beginner to competent to proficient and expert, using that framework that was proposed by Dreyfus, you could see that Dreyfus framework actually has the word competent right in the middle. And you could say this is not, it's actually a sensible idea to think of training and allowing learners to start work like practicing unsupervised when they are ready for that, when they pass that thresholds and they are ready for unsupervised practice, which actually doesn't mean they will not grow in proficiency. Of course they will afterwards, and everybody who practices after training will acknowledge that they would get better and better. But there must be that one moment that you say, well, now you are ready. We've observed you enough that we can make a justified entrustment decision for unsupervised practice. And you could apply that to one APA, but not all activities are just as difficult or easy. So there's differences in that. And if you draw that same threshold line of competence, you could easily see that there would be different moments in a training period where a person would be ready for unsupervised practice of an activity. And if you keep on practicing that activity, of course, you will get at higher levels of proficiency. But if you don't, there might be a critical activity that if you have not practiced it after 1 year or 5 years, we might want to rethink where we trust you to actually do that. Or there could be an EPA that you have not even been trained in a training period, but that is something that is acquired after training in a later stage, and you would add that to your portfolio of APAs where you could be considered qualified to practice. So if we actually use that model and then say, well, there's not only supervised or unsupervised, but there's actually grades or shades of supervision, you could see that as a readiness to just observe your starting to come in the healthcare space as a medical student. But then after a while, you could say, well, there might be direct supervision, and direct supervision really means there is somebody in the room actually observing you, can take over, providing proactive supervision. Indirect supervision would be there's not somebody present, so you would be allowed to just work with the patient by yourself, but then report afterwards. But the indirect supervision really means there is somebody available. If you really need help, you could quickly have a supervisor to assist you or to come to answer your questions. Level 4 would be a distant supervision, which means that there is nobody quickly available. So you're basically meeting the standards of your program because you're ready for unsupervised practice. If you really need some, you can always call one, and that's also holds for after training. So if you have a difficult issue with a patient, you're usually able to get some support from your environment anyway. So that would be a summative decision for unsupervised practice. And if that would be an EPA that is not quite completed, or actually you're not completed with your training, you could see that this would be a decision that is actually made in a phase of training that is not yet completed, but there is a phase that you have that full responsibility for practice. And it's a little bit odd to think that all EPAs should be finished at the end of training, and you would not be allowed actually to practice unsupervised while you're still in training, and there might still be like a sort of distant supervision available. So that was all talking about EPAs and entrustment within layer 3. So you could say that even in early stages, medical students can be trusted to make small contributions to healthcare. As soon as you would say, as a to a medical student, you go ahead, do this, report back to me, and we're not going to check everything anymore. Then is where contributions to healthcare start. So residents then, of course, may gradually build their specialty portfolio with larger and broader EPAs, but also specialists can develop a scope of practice using actually a dynamic, adaptable portfolio of EPAs that some EPAs may even get lost if you never practice, but others may be added in your portfolio. And then, so even after your certification, there could be dynamic moments actually leading to a situation that at any point in time, you should be able to know, and maybe even your environment should know, what are you qualified to do in a safe and a quality practice. So that is all about layer 2. Now let's go to layer 3, personalized competence. This is a nice paper actually from Tevez Apremian, who actually studied how surgeons in residency training find that they need to discover where the difference is between principles and preference. And the principles would be like the canonical way to do things in surgery, but the preference would be this surgeon does something in a different way than another surgeon, and they're both qualified. So here's where that threshold, what is a principle and what is a preference, should be sorted out by the residents, and that's one of the things that they find difficult. Some procedural variations are negotiable and others are not, and some are personal and some others are not. So the idea of a personal style of patient care makes physicians unique in their excellence. And so it turns the science of healthcare into the art of care on top of canonical and contextual competence. So if you think of other domains like arts or theater actors or architects or restaurant chefs or industrial designers or even other professionals, they all meet usually important standards of knowledge and skills, but are often valued for their unique style. And a key concept in personalized competence is something that I'd like to explain to you that is called by a Russian word, переживание. So competence stemming from perceiving was explained by a person some of you may recognize this person. It is the educational psychologist Lev Vygotsky, who is known for things like the zone of proximal development or cultural historical activity theory, but he also studied the emergence of artistic excellence. And that is where he used that concept of переживание. It is a Russian concept. It's not very easy to translate, but it really combines something that you could say experience plus emotions plus subjectivity. If you, and based on several sources in the literature, this would be a reasonable explanation of what it is. It is a subjectivity which makes individuals unique in their creative performance, being the resultant of the combined cognitive and emotional experiences built across one's lifetime, integrated into the long-term memory and informing one's frame of reference in viewing the world. That actually makes everybody unique. Even if you are meeting standards of professional practice, then you could still be different because you have a different biography, you could say. And the perceivание of one person can never be fully understood by others. And here's where I would say vocational competence becomes an art. So when does vocation become an art? You could say you have to just create things, and at a certain point, there are things that become unique in the products that you are creating. Here's Stradivari actually creating a violin that we almost now would call it's a piece of art because it's different from any other violin, even though it's a violin, even though it meets all standards of conditions. Here is a painting, and that painting was actually solicited by the members of the Amsterdam Surgical Guild and painted by Nicolas Maas. And they didn't have photography, of course. So here every member of that guild wanted to be pictured right. But now we will call this a piece of art. So here's where, if you would call a different artist, it would have been a different picture of that guild. Let's look at Picasso. Picasso's paintings across his lifetime have changed in the sense of building on a foundation of skills, and you can see that in his early work, which is actually very naturalistic. And here's a healthcare kind of image here that you could see that was Picasso in 1897. But by the end of his life, it was completely different. And if you even look at stages of development of Picasso across a lifetime, you could see that his art, individualized art, increasingly dominates on a foundation of skill. So level 3 is actually towards a harmony between a professional and a personal identity at the highest level of one other theoretician, Abraham Maslow, actually would call self-actualization in his hierarchy of motivational needs. You are probably familiar with this hierarchy. There are people would say, with the first thing is you need is physiological safety, physiological needs being satisfied, and then safety needs being satisfied, then belonging and love, and then esteem needs being satisfied, cognitive needs being satisfied, aesthetic needs being satisfied, and self-actualization then is the desire for self-fulfillment, to become actualized in what one is potentially, varying greatly from person to person, is what Maslow said. Being creative and then, quote unquote, relatively unfrightened by the unknown. Your basis is strong enough that you could actually adapt and actually create your own way of doing things within a foundation and a background. So again, the personalized art of medicine is the full self-actualization integrating the personal and professional identities. It requires a sense of mastery and skill to work in a context, and autonomy to develop personal practice preferences and habits and convictions. So layer 1 and 2 focus on meeting standards, whereas layer 3 is actually much more focused on a desire to develop and actually to set your personal standards. So that is layer 3, and layer 3 would probably become more dominant over time, where you actually are satisfied with all the background that you already have, and then can develop your personal way of patient care. So I'll end with a few implications of the multi-layered construct. So you could say that what it helps to do a little bit resolve the tensions that we feel between, there's a need for standardization in healthcare because we want to make sure that all health care is done safely and at a sufficient quality. But there's also context requirements, and there's a space for individuality and diversity. So it combines actually those three things. And then it reconciles also a tension that you could feel between the academic freedom of universities. And universities are there to help develop individuals to become themselves in their eventual skill and proficiency, but also at the same time meeting quality standards in healthcare. So universities and hospitals or healthcare environments might have a sort of tension. And with this model, actually, we can show that we could actually meet both elements. And it's also helpful to for taking a stepwise entrustment and increasing the legitimate autonomy, and to take that seriously in the context of patient care, to actually create educational environments where people can actually make those steps across their development. And then valuing the individuality and self-determination of individuals to foster intrinsic motivation to develop, which probably in turn also affects well-being and academic productivity. If we know that there's a huge literature actually on self-determination theories that actually says that it really supports the idea of well-being and academic productivity. So again, implications. If we think of canonical competence and think of where we are heading, and in the future also, we are now actually complying with the idea of competency-based education. It might be more important to think of competence for all those who are in training and less focus on the competition between those people. So those entering medical school are already among the brightest people, and maintaining a competitive medical education culture is probably dysfunctional. So, and you could see that already happening now. Grades in clinical education are gradually being replaced by pass and fail. Make sure that everybody meets those standards, even though if it would cost more time for some people. And then honors and cum laude qualifications are gradually disappearing. You can see that too. In my country, it's also happening. And of course, as you know, the United States Medical Licensing Exam Step 1 had abandoned the publication of grades and just giving pass-fail, which gives some problems. But the basic idea, I can understand that well. And you may even think there's some discussion in the literature you can see now about the match procedure, which actually blocks the idea of time variability, which is kind of invariance with different countries. Just as an example, my own country has a 6-year medical undergraduate program, but on average, I would say all students on average actually take about 6.5 years to complete that. And nobody actually really is concerned about that. There is variations, at least for between like 6 years and 7 years. So there's quite a bit of variation there. And that is also one of the reasons is that we don't talk about cohorts of students that are labeled at the moment they start with training, when they're supposed to graduate, or we have a matching program that requires people to meet the conditions of completion of training at the same time in the year. Even the Canadian competence by design model blocks a little bit time variability. I'm slightly critical about that idea, and there might be reasons to rethink that too. So one of the things of canonical competence that will happen in the future that we're not sure about yet is what will artificial intelligence actually have for implications on our definition of what canonical competence is and canonical knowledge and skills. So AI will probably refine the things that we are requiring learners to have in their rote memorization. We have to rethink that. And I cannot give an answer, so what that will look like, but I'm sure that it will keep us busy for the coming years. And there's a sort of an evolutionary law, you could say, that relevant knowledge will only stick if it's needed and used. So if you don't need that knowledge by heart because there is a device in your handheld mobile device that actually gives a better answer than you can give, you'll probably use that better answer. So we'll have to just see how that will actually lead to the way we have to train individuals. But the advice actually to students and teachers in schools, some are hesitant to embrace AA tools with caution. I would say don't hesitate to do that, but embrace that because it's going to happen anyway. There's no way that we can stop the use of AI tools. So we'll have to live with that, but also seek the benefits of it and make it, give it a place in our education. And here's actually in the New England Journal of Medicine just a few months ago was a suggestion that for the use of AI in medical education, actually in medicine in general, educators should take the lead. And then contextual competence, APA and entrustment thresholds, as I talked about, might be taken more seriously. People are very wary of giving autonomy to learners, even though they would be qualified to have that autonomy, but there are some restrictions to that. But we have to find ways around that. So if I read about entrustment decision-making in the literature, too frequently I would read of entrustment decisions not really being decisions, but actually determinations of an entrustment. So if we are serious about progressive autonomy, we have to think about ways to create that progressive autonomy. Just think of having your driver's license because you have passed your exams and everybody knows that you can actually drive, but you will not give that license until next year when for some reason we find it more important that you only are licensed to practice, even though we know that you can do it, but at a later moment that would be an odd idea for a driver's license. So how do we do that differently in healthcare? So another example that I can show you is on contextual competence, is that our context, we have to think of our context as things that are somewhat under threat. Think of the pandemic situations where we ask people to do things that they were not always competent to do just because we needed the hands in the ICUs or the wards during COVID-19, or climate change, or warfare, or migration. So healthcare workforces must be trained to be flexible, using EPAs might help for that. There's one big project, I would say is not because of those threats, but because of different reasons, but it's actually being recreated for postgraduate nursing education. And until now, actually, they're all training programs were silos that were independent of each other. It's completely revamped to a flexible EPA-based landscape that leads to situation. There's enhanced career perspectives because nurses can now actually add a combination of EPAs to be trained for, to be actually be doing things that they would like to do, or they are asked to do in a specific context. And so there's a better adaptation to the healthcare needs and enhanced career perspectives of nurses. So personalized competence then is focused on fostering self-determination, trust, and tolerance for diversity. So self-determination theories is about satisfaction of needs for autonomy, for competence, for relatedness, and that fosters intrinsic motivation, well-being, and productivity, as I said. So self-actualization and self-determination is exceeding the external standards of competence, and it is actually needed to optimize satisfaction in professional practice. So schools of health professions education and healthcare institutions should adapt to these needs to decrease burnout and attrition, and to remain attractive for individuals. Fostering individuality should also go hand in hand with a tolerance for diversity. If we are really serious about the fact that people may differ, we should be tolerant for that difference and diversity too. So having said that, thank you very much for your attention. There's a lot more to say about, but we are just at the end of the 45 minutes for this grand round. So thank you very much.
And with that, we do have some time for questions. So feel free to come off of mute and just ask the question, or I will monitor the chat as well and ask them on your behalf.
It's always funny when you have audience, as you suddenly ask them questions and there's nobody responding. There's always two things that you can think of. Either everybody has understood everything, or nobody has understood anything.
I've come off mute, Rob. Thank you for this. My name is Kelly Shaw. I'm a licensed clinical psychologist, and I am not part of the teaching faculty for the physicians, but I support graduate medical education's efforts to support the well-being of residents and fellows. And oftentimes my participation in grand rounds this is a bit above my head, but I so appreciated the tie-in that you made to well-being and how longevity and fulfillment and self-actualization, a key part of that is the autonomy and the ability to perform and develop and be creative and all of that. And so I just wanted to say how much I appreciated the tie-in and taking it beyond simply academic performance and competence, and tying and seeing the developing physicians as humans who have needs beyond simply competency and clinical skills.
Yeah, thank you for that comment, and I completely agree with you. And so I think it's good to every once in a while to make clear that if we talk about standards and competence and competency-based education, we should not lose the idea that people are always also different, and they have to be different. They have to find their own pathway to keep motivated and to keep self-determined. But it's not to say we're not doing one or the other. We're both actually say, well, that people have to comply with standards, but at the same time, they're all individual. They're also individuals.
There is a question here on the use of AI in medical education and whether you have any recommendations. And I'll just take a moment to do a shameless plug that folks can go back to the foundation session that Raghu and I did on AI and MedEd from about 2 months ago. That's hosted on the faculty development site. But Dr. Tinkata, I'd love to hear your ideas for implementing AI in medical education.
Yeah, the funny thing is about AI, so you are probably, or many people are much more expert than I would be on AI, and I'm just also a learner here. But I do think it will definitely affect us, and it did definitely affect educators, and we're all already looking at. So it only exists like in practice that we could actually use that only a year. So we're in a very early stage, but definitely. It will affect education, and it has affected healthcare already in specific domains very significantly. Yeah, so and I cannot say very much more than I did now, because it's just such a new era that we're actually embarking on. And I'm sure that as again I said,
look at that combine, guys.
Hello. Yeah. So I do actually think that the idea of the evolutionary law, or the idea that if you don't use like your knowledge and skills because there is an alternative that actually that has a better productivity than what you use, you will probably lose that too. And we know that, like, from navigators in the cars, if you so my personal geography like skills in driving around have really decreased, because there's always a navigator that does a better job than I would do. So then I started losing that, and like the studies that were done about the taxi drivers in London, they had a different actually wiring in their brains to be able to navigate through London. But that's all gone now because they don't use it. If we have devices that actually can do a better job than we could do, we'll probably use that device too. So that's going to happen with our work using AI too. At a higher level, we need to understand how to use it. So at this moment, like making prompts for GPT is the skill that you really need. But I'm sure, and I have to be very modest in this because I am truly not an expert in AI.
Good morning, Dr. Tankata. First, let me just say I'm a huge fan. I'm not sure how often you get that, but I really do appreciate the opportunity to see you live as opposed to a recorded version. So thanks for being with us. I read the paper that you and a friend of mine, Jenny Jarrett, wrote regarding the would I trust, will I trust, and you highlighted that here. And I'd like kind of your input of how, as we develop our faculty, to get them more comfortable with that difference between competence and proficiency, because I think we understand it in theory, but when you have to turn the reins over and the person isn't quite where you are after 10, 15, 20 years of practice, you wonder, it's hard to draw that line. So, what are some development, or what are some things that we can reassure our faculty that it's okay, because they do need that independence to be able to learn, as opposed to kind of all of a sudden they're not with us and they're not ready to practice independently?
Yeah, that's a good question. And I also, let me start by acknowledging that I understand why people are hesitant to do that. At the same time, what I usually say to people, if you keep providing close supervision until the end of training, and that also holds for postgraduate training, where if you cannot discharge a patient without a certified specialist having seen the patient, and not even seen, but even examined the patient and made all the decisions, then you as a resident must realize that after training, you have not really experienced that full responsibility. So that's to start with, is that is actually, I would say, something that you really want to create in your educational program. And that also holds for medical students. Now, the question then is, how do you actually do that? How do you create a situation that people really feel that deep responsibility? Because it's now on them to do that work. So I have some discussions with the surgeons. In surgery, very often surgeons need to be, like the senior surgeons, need to be in the operation room, where learners actually are be closely supervised. We would call that supervision at level 2, so people in the room. So, but still, you could think of things that learners might be able to start doing when they are, of course, they have to be observed and they have to be assessed, that they can really do that. And you want to feel safe that they can do it. But then you could start doing, for instance, doing some administrative work, even if you're in that operation room. Or I could refer to literature written by a Swiss surgeon called Jennifer Claassen, and she actually shows that how you as surgeon can actually give some autonomy. There's a paper that she wrote called "Whatever you do, I can fix it," which actually means I can give you some space to just go ahead because I am there as your safety valves or safety net that I could correct things if I feel that the things are not doing well. So for medical students, then people are hesitant because they would say, well, a medical student is not licensed. So we have started creating. Some years ago, Kerry Chin actually led the paper in academic medicine about a scale of supervision that is more detailed. And level 3 of supervision is actually indirect supervision, which means there's not a supervisor at that space, but quickly available. Within that level, there's 3 sub-levels that we have defined, A, B, and C. So A would be that everything is checked afterwards. B is key findings is checked afterwards. And C would be there's only a check on the student's request. So here's where you could start providing some autonomy. There's still like the responsibility that you have. You might have reporting afterwards, but in some cases, you don't always have to see the patient. So here's where you could start providing some autonomy, and you have to think of that. And every specialty would probably have a different way. Surgery is definitely different than internal medicine or emergency medicine or radiology, but there are in each of those specialties. I think you can create the steps, or you can think of the steps you can create to provide that autonomy. We recently published a paper in about dermatology training in the Netherlands, where students getting that EPA are actually given that autonomy if they are qualified to do so. It was published in the Clinical Teacher just a few weeks ago. So I think you have to sit down, and I'd be happy to with anyone would be interested to dig deeply in. So what does it mean for a specialty? Like my discussions with the surgeons in San Francisco, thinking of ways to actually create that progressive autonomy.
That's fantastic. Thank you. And who was the author behind the "What You Do, I Can Fix It"? What was I missed?
Yeah, her name is Jennifer Klassen. So her last name is Klassen. If you would Google Jennifer Klassen, you would find that.
Wonderful. Thank you.
And with that, I think we have come to the end of our time. Dr. Tinkat, thank you so much for joining us. Like Dan said, it is amazing to be able to actually learn from you in person versus watching recorded videos. So thank you.
Okay, my joy, my pleasure. Thank you.